My name is Carol DeFelice, and I'm a ThyCa volunteer. I'm a papillary thyroid cancer survivor since 2008, and I live in the Boston area in Massachusetts.
Hi, everybody. Welcome to session 306, Pediatric Thyroid Cancer Roundtable. It's a parent story about NTRK, positive thyroid cancer, and discussing the importance of tumor testing, as well as latest updates. I'm Susan. Welcome, everybody. A little about myself. I was diagnosed in 2004 with papillary thyroid cancer. And then through biomarker testing, I was diagnosed with NTRK positive thyroid cancer in 2018. And I've been on an NTRK inhibitor for more than 4 years. I'm also the founder of the NTRK Facebook support group and patient founder of the NTRKers Foundation. I'm very pleased today to have two amazing doctors. First, we have Dr. Andy Bauer, who is a pediatric endocrinologist and director of the Thyroid Center at Children's Hospital of Philadelphia. Dr. Bauer retired from the United States Army after 29 years of service, and which included 2 combat tours in Iraq. His clinical interests include research, the study of pediatric thyroid disorders, thyroid nodule disease, thyroid cancer. He also serves as co-chair of the American Thyroid Association, a pediatric thyroid cancer guidelines, and is a member of the ATA board of directors. In 2018, he served on the World Health Organization, the International Agency for Research on Cancer, which is an expert group that published guidelines on thyroid screening after nuclear disasters. He has spoken at many past thyroid events, and Dr. Bauer is also a ThyCa medical advisor. We also have Dr. Laetsch, who is a pediatric oncologist at Children's Hospital of Philadelphia. He leads both the developmental therapeutics program and the very rare malignant tumors program, as well as holding national leadership roles in each of those areas within the Children's Oncology Group. In the DVL program, he conducts early phase clinical trials of new treatments for children with different difficult to treat cancers, with a particular area focusing on molecular targeted therapies that are designed to block specific genetic mutations identified in patients' tumors. He leads the pediatric development on NTRK inhibitors for children with NTRK gene fusions, and now leads the COG nationwide clinical trial studying the ability to use NTRK inhibitors instead of chemotherapy for children with one of these gene fusions. And also today we have 2 special, very special guests, Kristina and her daughter. So I want to start with Kristina giving a summary synopsis of her journey and how she was ultimately diagnosed with NTRK positive thyroid cancer. So Kristina, I'll turn it over to you.
Thanks for having us. My name is Kristina, and this is, she was diagnosed in January of 2019 with papillary thyroid cancer. It was, I guess, just a really big shock because she went in for a biopsy of a lymph node that had been enlarged for several months. And we were just thinking it was not cancer. We even heard from the ENT, this doesn't look like cancer, it doesn't feel like cancer. So when it came back positive for cancer a few weeks later, it kind of rocked everybody's world. So things like quickly went into place with surgery and ultrasounds and CT scans, because she was only 9 at the time. So it was a really, really scary time for her. We initially had treatment at which is where she had her surgery. They did a phenomenal job, but once it came time to seeking out treatment for radioactive iodine, we decided to get a second opinion through CHOP, and it was the best decision for us and our family, because they have been just the missing piece to this journey. And I can't thank them enough for just being along with us for this, because they've just been incredible. tumor was tested and I didn't know it, so I'm grateful for that. It was tested as soon as her tumor, she had her surgery. It actually came back, the results came back from that when we were in Philadelphia for her first radioactive iodine treatment. At the time, I had no idea what any of that meant. I just knew that it was good that we knew what it was and knew that there were other options from NTRK, because she was positive for the NTRK genomic testing. So we've been seen by Dr. Bauer in Philadelphia since January or February of 2019.
Thank you, Kristina, for sharing that. Dr. Bauer and Dr. Laetsch, can you just give a quick overview, whoever wants to take it, on what NTRK gene fusion is and how it's tested?
Sure, I'm happy to answer that question. So NTRK gene fusions are a genetic change that happens only in the tumor. So first of all, this isn't a genetic change in the patient. This is just a genetic change in the tumor. And it's where two genes that are not supposed to be stuck together get stuck together. One of those is an NTRK gene and one of them is something else. And what that does is it makes the NTRK gene be turned on all the time. And so that causes cells to grow uncontrollably, and that makes cancer. So we think this is one of the very first things that happen in the development of some people's cancer, where you get one of these genetic changes that causes the NTRK protein to be turned on all the time, leading to the cancer. And also importantly now, leading to sensitivity to drugs that block these NTRK gene fusions.
So when is the appropriate time to actually, I'm sure you see lots of pediatric, especially thyroid patients coming through. So when is the appropriate time to actually test these patients?
Andy, do you want to answer that?
Sure. So there's two opportunities, I think, for testing. But when we have patients that come in with a thyroid nodule and undergo a biopsy and the results are not negative and they're not positive, we call it indeterminate. They're in the gray zone, which is a Bethesda category 3 or 4. That is an appropriate time to do testing to see if the cells have any of these specific markers. We call them drivers, genetic changes that are associated with the nodule being more likely to be cancer. In case, for patients that present with disease that's involving lymph nodes and especially distant metastasis, which most commonly is in the lungs, we are testing more and more these days. We've been doing this kind of regularly since 2018 or so at CHOP, but there's more centers that are now doing this on a more regular basis for patients with distant metastasis or widely invasive metastasis, even in the neck, because of, as Ted mentioned, there are now opportunities to think about other medications that are available that weren't available 5 or more years ago within our field, to maybe alter how we're taking care of our patients. Most importantly, for patients that have cancer that isn't responding to radioactive iodine, but even now starting to think about it for patients sometimes even before surgery. So it depends on the patient and how they present, but we believe there's more and more opportunity to know what these genetic changes are, because it can change the accuracy of diagnosis and the opportunities for treatment, for making other treatment decisions.
So we heard the word test a lot. So we know there's many tests out there. So what is appropriate for determining if it's NTRK? Because not all tests are created equal, as we know. Dr. Bauer or Dr. Laetsch can take that one.
Sure. So the best tests, I think, for identifying the genetic changes in thyroid cancer are broad sequencing tests, because those can identify these NTRK fusions. And as I mentioned, there's lots of different partners that can be associated with NTRK gene fusions. So it's not only one specific genetic change, there's many. And sequencing tests or next generation sequencing is often the best test to identify many different changes at the same time. we're talking today about NTRK, but there's also RET fusions and other alterations, BRAF mutations that also occur in thyroid cancer and also are targetable. And so that other benefit of a sequencing test is it lets you identify all of these different potential genetic changes with one test so that patients can identify, or so that we can identify potential therapies for our patients.
Great. And so once a patient, a pediatric, is diagnosed with NTRK positive thyroid cancer, when's the appropriate time that they would start therapy?
We'll probably both answer that. It's a great question. That's still, we're trying to figure out exactly, as a group rather than as a patient, when the best time is. So the most common, we call it adjuvant therapy for a patient who has radioactive iodine refractory disease, which is pretty well defined in adults, a little less so in pediatrics. That means either one of two things: either the tumor does not absorb radioactive iodine, and so doesn't provide us an opportunity to use that drug in treatment, or it actually does absorb radioactive iodine, but the radioactive iodine doesn't kill the tumor, and the tumor continues to grow. And so in adults, it's defined. And there's criteria for that in pediatrics. We're trying to move that definition and make it more specifically applicable to our population. And so for now, that I think the most common group of patients for both is our patients that aren't responding to radioactive iodine, whether or not absorbing it or absorbing and growing as the most common. And as I mentioned, and we'll probably talk about after, there are other opportunities in research also with NTRK drugs and other targetable drugs that we're starting to look into to even figure out if it makes radioactive iodine more effective, even for the first dose. So, Ted, any other contributions to that?
No, I agree completely. I think, I would sort of divide thyroid cancer into different categories based on how far it's spread initially when it's diagnosed. And so, there are some patients who, as Andy mentioned, just have a nodule in their thyroid or only have disease limited to the neck. And those patients are often able to achieve no evidence of disease with surgery alone or with surgery and radioiodine therapy. And at least at the current time, probably it's not the right thing to treat the majority of those patients with a selective inhibitor because the outcomes are very good with standard therapy. The patients who have disease that's spread outside the neck to the lungs or other places are patients that we're definitely studying when the right time is to use one of these drugs, an NTRK inhibitor, to try to understand whether they should be reserved for those patients who, as Andy mentioned, don't respond to radioiodine therapy, or whether even moving them earlier, potentially before radioiodine therapy, may be useful. I think the other time we think about potentially using these drugs is they're very effective to shrink tumors. And so in patients who have very large tumors initially where surgery might have increased risk, it's another opportunity to think about whether or not those patients would benefit from treatment with a drug actually potentially before surgery to facilitate a safer surgical resection.
Right. So these drugs, as we know, have like a phenomenal effect on tumors and lessening the burden of disease. So with the pediatric world, is there any, I've heard of some pediatrics actually going off the drug for a while and potentially seeing if they can cure their cancer, but I know cure is not the word. We just keep it stable, I guess is the better word. Can you just Dr. Bauer or Dr. Laetsch, comment on that, on taking a drug holiday and what we're seeing in that space?
I can
leave that up to Ted. Can take the first.
Yeah, I'll take the first step. So I will say, first of all, this has been something that's been more studied outside of thyroid cancer than in thyroid cancer. And because these same genetic changes happen in other tumors beyond thyroid cancer. And in pediatric patients, the most common reason we've treated patients is for a sarcoma, a different kind of tumor. And in those patients, we do have growing experience with taking a drug holiday. And there are a subset of those patients who seem to be able to maintain a complete remission. I think you're right, it's too early to use the word cure, but maintain a complete remission for several years off of these therapies in some patients. And so I think certainly when we're treating younger patients who we hope and expect have, decades of life ahead, we want to see whether or not we can avoid the need to take a lifelong medication. And so something we're interested in studying in thyroid cancer as well. There are a couple of approaches. One is just a drug holiday, just stopping the drug and seeing if you can maintain stability. And the second is actually potentially using these medications to augment the effect of radioiodine so that we can maintain a durable deep remission for these patients. And so there's case reports of data where we combine the drug with radioiodine and show that the drug helps tumor cells take up radioiodine, which may make it more effective. And so that's something that we're now doing for some patients.
Dr. Bauer, do you have anything to add?
Yeah, I think the last point is kind of one of the more exciting opportunities that we're starting to investigate in treating our pediatric patients. And so we know these drugs, as you described, help shrink the tumor. The question is, in thyroid cancer, does it help kill the tumor? And we don't know that. There is some evidence in other tumors where that is the case. We just don't know that within the pediatric or even the adult papillary thyroid group. So if we can shrink the tumor, and as Ted mentioned, it also increases the number of transporters in the membrane of the cells that allow radioactive iodine to get into the cell. So you shrink the tumor and you give more opportunity for radioactive iodine to get in, then that gives us a chance to take advantage of the best of both worlds as far as treatment, decreasing size and then increasing avidity or the absorption of radioactive iodine to help kill the tumor. So we're beginning to develop this understanding, and now we need the ongoing data to see if that actually is happening. We know for sure it does those two things: decreases size, increases absorption of radioactive iodine. Now we have to see, does the combination actually help achieve stable remission with minimal disease or no evidence of disease, which was the goal of all of our attempts at trying to take care of our patients.
Excuse me, are most NTRK tumors non-avid to iodine? Is that typical, or I know it takes a while to figure that out in patients anyway.
Right. Most in pediatrics, again, I think everything in pediatrics is a smaller number than adults, but most of our patients have avidity, but it doesn't necessarily, the radioactive iodine doesn't necessarily kill the tumor. So if you look at, probably there's about 5 papers published on pediatric patients with pulmonary metastasis spread to their lungs, not all of them NTRK, but fusions. NTRK, RET fusions, ALK fusions are the most common associated with lung metastasis in pediatrics. Only about 10% can we achieve no evidence of disease. And so it's not that it's not absorbing it. It appears to be, for the most patients, it appears that it's just not killing the cancer as well as we would have hoped. And that's with decades of data. So our patients do well, they have stable disease. But that's a big burden to know that you still have cancer left, even if it's not growing. And so that's why we're so interested in trying to combine these things to see if we can really make an improvement, because it's nice it's not growing, but the best thing would be that we can destroy it, and so there's no evidence of it.
Mm-hmm.
I would also just say that there's different degrees of avidity, so that absolutely the majority, almost all of our patients have RAI avid disease, but there are examples of patients where we see RAI avid disease that gets much, much brighter on a scan when you're on one of these medications. And so they were avid before, but they take up much more of the radioiodine after, and that may lead to more efficacy just by having more of the radiation localized to the cancer cells. There's also the potential that there's a benefit of targeting the cancer cells in 2 different ways using one of these inhibitors as well as radiation at the same time. But it's not completely dichotomous in terms of avid or not avid, that there's degrees.
Dr. Laetsch, you alluded to this before, and as we know, NTRK fusion is found in over 22 cancer types in both pediatric and adults. Is there any difference on how thyroid behaves versus other cancers?
So the NTRK fusions definitely behave differently based on the tumor type. So for example, in pediatric patients, the most common sort of single tumor where we've seen these is something called infantile fibrosarcoma, which tends to be a localized tumor that doesn't spread when it has an NTRK fusion, versus thyroid cancer, for example, where we know that fusions like the NTRK gene fusion make tumors seem to be more likely to spread than other genetic drivers. So there definitely are differences based on the tumor type. And certainly things like we're talking about also with using radioiodine wouldn't apply to tumors that are not thyroid cancer, because that's really a thyroid cancer specific therapy.
And is there any research on, and this may be a little, you can't answer, it's fine for today, for the different fusions, because we know we have NTRK 1, 2, and 3, and they bind with different partners. Is there any research on the different types of fusions that are coming out in thyroid cancer, or a difference in how it behaves in somebody?
Yeah, so it's an excellent question and something we're still trying to investigate. In the preliminary data, I don't know that we've looked in thyroid cancer specifically, but in the preliminary data across cancer types, we don't really see a difference depending on the NTRK 1, 2, or 3. And you're absolutely right that normally the NTRK genes bind different receptors, but in these fusions, we think they're actually active independent of those receptors. So there may not be as big of a difference between the fusions as there are between the genes when they're normal.
But it is an area that we're actively researching, because we lump these cancers into different driver, classes, whether it's a RET fusion and NTRK fusion. But there's clearly other things that impact it, because we have some patients with NTRK fusion that have very little, if not any, metastasis. And we don't know if it's just we caught it early, or if there are other things going on that allowed those cells or prevented those cells from spreading. And so we're mostly talking about the genetic, the DNA, RNA level changes, but there's other things that impact how cells react outside of these drivers. The drivers kind of are lumped into classes or different descriptive pools of different that allow us to target. But what's happening with microRNA and proteins and other things that are also involved in allowing a cell to grow and allowing a cell to move, we need more information on that, because they're clear. There are differences when you look at the patient population with NTRK 1 or NTRK 3, and even within NTRK 3, what fusion partners, or even in the same fusion partner, how it behaves in individual people.
In the thyroid adult world, we hear a lot about the TERT promoter. Does that occur in pediatrics, and what does it really mean for TERT?
Probably a combo response. Should I start that?
Sure.
So TERT in adults is oftentimes associated with BRAF mutation-driven tumors, and it seems to be associated with more invasive, less responsive to treatment disease. In pediatrics, we have tumors that have TERT mutations, but it appears to be less common, and it doesn't seem to have the same implication. And that may be because we just haven't tested enough children yet, or it might just be that it behaves differently in pediatrics. And that's one of the reasons why we have pediatric thyroid centers and adult thyroid centers, and we're all interested in the same thing, improving care. But it really does matter where you receive your care, because even with the same genetic change, the tumors behave differently in the host of the person. And so TERT is probably on that list of, why is it different in adults and pediatrics? But it appears to be.
Yeah. And I would just say, I agree with everything Dr. Bauer said. I think it's something that we need more information about. I might use this as an opportunity to highlight there are a number of ongoing studies trying to identify what these genetic changes means. So we have one that that Dr. Bauer leads here at the Children's Hospital of Philadelphia, but then also through the Children's Oncology Group. We just this week with government NCI funding are able to offer any patient in the United States with a newly diagnosed thyroid cancer, any child in the United States with a newly diagnosed thyroid cancer, sequencing through the Children's Oncology Group. And part of the reason for doing that is to help the patient, but the other part is to allow us to learn. And so we're going to aggregate all that data and try to understand better what these TERT mutations and other alterations that we see in thyroid cancer in children mean, just because we haven't had enough patients yet in the pediatric space to, I think, fully evaluate what they all mean.
Right, well, that's exciting. We need more research. So Kristina, a question for you. If there was one thing in you and journey, what would you have done differently, potentially, in looking back the last few years?
That's a good question. Honestly, looking back, I don't know as if I would have, I guess, sought about immediately. They were really the whole path changed since we went there. I felt like once talking to an endocrinologist I just felt like we had no hope. She just was not a good fit. And as soon as I called CHOP, I just knew this is where we're supposed to go. Lindsay, the nurse there, was just phenomenal. And just once getting there, they just made you feel like this isn't the end of the world. This isn't the end of the road for you. We're going to help you. And they just gave us a lot of hope and just a lot of positive. That would be the only thing I think I could want to change looking back, other than obviously just not having to have through any of this.
And on the other side, if there was one game-changing moment in your journey, what would you like everyone to know about?
Obviously, I'm really thankful that tumor was tested. I think when you first hear that cancer diagnosis, you're in a whirlwind of emotions and not really knowing what you're supposed to do next. So I'm thankful that that was done and that it was an option for her, that there wasn't just radioactive iodine and that was it for her. So I'm very thankful that the testing was done immediately. It's something that we didn't have to wait for to happen once we knew that, because she did respond, I believe, to the radioactive iodine, but maybe not as much as she did this past time. So I think is a perfect example of how the NTRK, the TrkV pill, worked so much better this time with the radioactive iodine.
All right. So Dr. Laetsch and Dr. Bauer will wrap this up. And just finally, one thing that you could tell patients, parents in the NTRK world of what we can expect to see, in the next few years, and then we can wrap it up for today.
It sounds like a combined response again. I think we're incredibly hopeful and optimistic that we have these initial NTRK inhibitors, but because these types of drugs are not specific tumor, there's a lot of people, even if we need more research in thyroid cancer, adult and pediatric, they're being researched in other patients with other tumors. So there should be, Dr. Laetsch will have more to say about it as well, other types of inhibitors that will be helpful if a patient stops responding, because that's all of our fear, right? When you start it, when you stop it, and what happens if it stops working. Those are typical things that all of us think about. So I think there's really great hope for that, and many people looking into that, and should be, even if it's discovered in a different type of tumor with an NTRK fusion, should be, studied and researched and applicable, hopefully, in thyroid cancer. And then two, as we've already talked about through this whole discussion, figuring out how to bring these types of drugs that are amazingly powerful with relatively smaller side effects compared to other chemotherapy that Dr. Laetsch chooses for other kids with other types of cancers. And so we just have to figure out the best time to use it. What's the right patient population? And What's the right timing of when to do it? Are there some patients it's before surgery? Is there some patients it's before the first dose of radioactive iodine, rather than waiting for that patient that's had surgery, had radioactive iodine, whether it's 1 dose, 2 doses, 3 doses, and it's not responding, and then we decide we should do something different. And so that last group is the one that we have the most information on, but we're trying to figure out the other 2 opportunities. And really the only way of doing that, we have a really big program at our hospital, but it's to combine centers and center information. And so through what Ted is doing on a national level as a primary investigator on NTRK drug studies, we also have we're building a pediatric, we call it the Child and Adolescent Thyroid Consortium, the CAT-C, that hopefully will allow other centers in the United States to join our efforts. And there's 4 other executive members of our CAT-C and about 25 other centers that are interested in internationally as well, so that we can build a global community, pediatric thyroid community, to try to answer some of these questions, because they're not going to be answered at one center. They're only going to be answered once we combine our efforts as a national and a global community.
I think, Andy, you gave 3 answers and took mine, but that was excellent. No, I agree completely. I mean, I think, what I expect to see over the next few years, definitely an increase in testing through these efforts we've already talked about, so that both individual patients can learn, and that we as a community can have more research to understand how and when to use these types of inhibitors, and also how we can use genetics to better understand the individual patient's risks and what therapy would be best for each individual patient. And then agree, I think it'll be really important to get the results of some of these ongoing studies, and to get future studies of these drugs to understand when to use them for patients with thyroid cancer, before, after, or in combination with radioiodine therapy, and to think about how to understand more how often resistance occurs in children with thyroid cancer, and if that occurs, to study other drugs, which we're now starting to do, that may be active against some of that resistance that can occur.
Great. I want to thank everybody for attending today. Thank you, Doctors Bauer and Laetsch, for joining us early Sunday morning, and for Kristina and thank you so much for sharing your story. You guys are doing awesome. So glad you could be here. And I hope everyone has a wonderful day. So thank you very much.